Good morning, good afternoon, and good evening to our speakers, Dr. Chetan Palmer and Dr. Adam Frampton, and all our wonderful delegates who are joining us from different geographies across the globe. It is indeed my pleasure to welcome you all to the BMJ Masterclass on Recent Advances in Gastric Surgery. Welcome all. Allow me to introduce myself as Dr. Gaurav Singh. I'm a clinical editor at the British Medical Journal, and I sit in the New Delhi office of the BMJ in India. BMJ, as you all know, is wholly owned by the British Medical Association, and as of today, we are much more than just the publisher of one of the world's most cited general medical journals. BMJ today is a global healthcare knowledge provider. And through these educational initiatives like the BMJ Masterclasses, BMJ Webinars, BMJ Online Educational Courses, BMJ Medical Writing Workshops, etc., we really work hard towards the enhancement and updation of knowledge of our fellow doctors and healthcare professionals. So before we start our scientific session, there are certain hygiene rules. You can post your questions in the chat box provided on your screen, and the Q&A will be taken up at the end. You can also download your certificate from the tab which is provided to you. If you're not able to download the certificate through the tab, we request you to please refresh your screen, and then you will be able to download the certificate. I would also take this moment to thank our sponsors for the day, which is Sun Pharmaceutical Industries Limited. Sun Pharmaceuticals has been instrumental in supporting the British Medical Journal and carrying out these educational initiatives. We are today joined by two of our senior colleagues from Sun Pharmaceuticals, Dr. Sameer Rao, who is the General Manager and Head of Medical Affairs and Clinical Research, Emerging Markets at Sun Pharmaceuticals, and Ms. Lorraine Thanikat, she is the Head of Marketing for Emerging Markets at Sun Pharmaceuticals. I would request you both to speak a few words before we start with the scientific session. Please, Dr. Sameer.
Thank you, Dr. Gaurav. A warm welcome, dear doctors, fellow colleagues, as well as the esteemed faculty members to this program today. It's indeed an honor to actually welcome all of you on behalf of Sun Pharma. Today's scientific session is actually attended by surgeons and physicians across 5 countries and 2 continents with the purpose of wanting to gain knowledge which could be implemented in our clinical practice. So let us make the most of this opportunity to learn from the esteemed faculty members, Dr. Frampton and Dr. Professor Parmar. Thank you. Over to you, Lorraine.
I just want to wish all the esteemed delegates out here a happy learning session and thanking the BMG team for arranging for this event today. Thank you.
Thank you, Dr. Sameer. Thank you, Lorraine. So, dear delegates, there has been a slight change. We'll first be starting with Dr. Chetan Parmar's session right now. Allow me to introduce Professor Chetan Parmar. Professor Chetan Parmar is a consultant bariatric and upper GI and general surgeon, clinical lead and head of the department, co-director research and innovation department of surgery, the Whittington Hospital NHS Trust, London. Professor Palmer is also the Honorary Associate Professor, University College of London. He is an Honorary Consultant, Barts NHS Trust. He is a surgical tutor at the Royal College of Surgeons of England. Professor Palmer is a very, very experienced bariatric and metabolic surgeon with an experience of over 3,000 surgeries and thousands of endoscopic procedures. He is also the editor for various reputed bodies such as the Obesity Surgery, International Bariatric Society newsletter, International Journal of Surgery, BMC Surgery, and Journal of Bariatric Surgery. Welcome, sir, and I would request you to please start your session.
Thank you very much. Thank you, first of all, for this kind invitation here. And it's a pleasure and honor to be here. And with the BMJ team, it's good to see you all. And let's hope it's informative and useful to the participants who are listening. So feel free to ask any questions. And I'm going to start my Hello? Hello, can you hear me?
Yes, you are audible, Professor Palmer.
Fine, sorry, I lost for a second. It just said Zoom muted, so I thought you guys muted me. I'm one of the surgeons in London, and I'm going to talk of emergencies in surgical practice. Next slide, please. I have no disclosures. no disclosures related to this talk. A brief background of why we are talking of emergency practices in surgery. As we all know, 80 to 90% of the deaths arising from general surgery occur in patients having emergency general surgery operation. And as you would all be aware who practice emergency surgery, that it's a high risk and high cost affair, which is, for example, in the England, it accounts for 14,000 adult admissions to intensive care in England. What I have not mentioned here is just for you to know that it's a budding subspecialty now. So not Hello. Hello. We also have emergency surgery as a subspecialty, and we now have dedicated emergency general surgeons who carry out the emergency work. Yes. So if anybody out there wants to do or pursue emergency surgery as a career, feel free to approach the UK government or the Royal Colleges. So today what we are going to talk are for few emergencies. We'll be talking of appendicitis, we'll be talking of hernia pathologies, and we'll be talking of gastric emergencies. Now, obviously, with your senior group, I'm not going to go much into the clinical assessment, but I'm going to briefly talk of the protocols and proformas we tend to use in the United Kingdom, called the NEWS2 scoring, the sepsis 6, frailty, and there. I also thought there might be a few trainees in, so I'm going to have some basic knowledge as well. So please pardon me if it sounds too basic for some of you there, experienced surgeons. Next slide, please. I think we skipped one slide. Yeah. So this is news. This is the new early warning scoring system, and it's updated now. So it's NEWS2. You don't need to click the link, so that's fine. This is just a link for in people who are not using it, or you, in case you want to upload this. Basically, this is a system to assess your patient, which will then warn you if the patient is becoming unwell and try to pick an unwell patient earlier so that you can treat them better. Next slide, please. So these are the parameters in what's known as the NEWS2. If you look on the left, and I think they are quite basic. You measure your pulse, temperature, respiratory rate, SpO2, and your blood pressure, and they give you a scoring system from 1 to 4, more than 4, or 5 to 7, and depending on that, the nursing staff. So mainly this is important for nursing staff and junior doctors to be aware at what point they need to ask for senior or a fellow help, or if they are in the red score, do you think they need to ask help from a consultant? So that's the NEWS2 scoring system. In case you are not using it, it's helpful for assessment. Next slide, please. I think everybody would have heard of sepsis 6 bundle and sepsis 6 protocol. In short, when a patient is recognized to have a life-threatening condition which is triggered by infection and which can affect one organ or multi-organ, you try to pick them early and you start your management. And it's quite basic. You take 3 things from them and you give them 3 things. You take blood test, you take blood cultures, and you take urine for measurement, and you give them IV fluids, you give them oxygen, and you give antibiotic. And as you can see, again, I won't go in detail. There is that website you can go on, but it will tell you what has to be achieved within the first hour, what has to be achieved within the 3-hour bundle, and what has to be achieved within the 6-hour bundle. And there are a lot of studies and audits now which have showed that, just like in trauma, there is a golden hour and things, even in sepsis, there is a golden hour, and you can save lives just by acting sooner, just by giving that oxygen sooner, just by giving a shot of antibiotics sooner. So again, please try to, in your emergency setup, put these posters on and try to use the sepsis bundles, I would suggest. Next slide, please. Frailty. I think this is probably not much talked about, and therefore I wanted to just highlight this a bit for you all. Mainly, this became quite prominent during the COVID times as well. Remember, there were a lot of trials and things going on, and I think, and for example, there were like 10 ventilators available or limited ITU, HDU beds available. People had to triage and assess accordingly. As we know, the geriatric population globally is increasing. Frailty is a multidimensional geriatric syndrome, which is associated with poor health outcomes. It also represents a decreased physiological reserve and function. And I don't, again, need to go into detail, but basically, the elderly patient would have less reserve to fight the problems. The reason why we need to do a frailty scoring is because it accounts for the increased risk of adverse outcomes associated with that. So if we know their frailty status from before, you can at least have that discussion with the family, what your emergency surgery outcomes are going to be. You can predict the morbidity, mortality, or even decide not to offer an operation. So I think this therefore helps in your assessment. So again, if you're not versed with it, I would probably advise you to have a quick look at it. If you go to the next slide, Gaurav, thank you. That's the clinical frailty score. Before it was just words. Now they have attached photographs as well, as you can see with it. So the first, as you can imagine, is a very fit chap who could run around, then would be well. As you go further, either with a walking stick or walking with crutches or going with a Zimmer frame, or even with Zimmer frame needs some help, wheelchair. And last one would be, say, housebound, not doing much, does need help with all the shopping as well, and frail overall. And the last one would be terminally ill. So that's the frailty score, and that helps you have that discussion and assessment. Thank you. Next one, please. So those were just a bit of assessment to do while the patients come in. First one, we'll be talking of acute appendicitis. And again, pardon me if this is too basic for the senior cohort of surgeons there, but I think for junior lot, a good history is always important, because you would realize more and more these days, people don't rely much on history because we have ultrasounds and CT scans available so easily. People tend to just resort to that rather than take a good history. So I would still say acute appendicitis in my practice is still more of a clinical diagnosis rather than a radiological diagnosis. So please try to be thorough still with the history. I think we all know typical history with appendicitis is periumbilical pain radiating to the right iliac fossa with nausea and vomiting. When we look for signs, rebound tenderness is where you have the tenderness in the right iliac fossa. Rousing sign is when you press on the left iliac fossa, you get a bit of tenderness on the, so you want a rebound tenderness in the right iliac fossa. Then there's something known as a psoas sign. If it's a retrocecal pressing on the psoas muscle, patient would be sore when you do that movement, which is shown in the picture. Fourth is an obturator sign. Again, those are for the deep pelvic kind of positional appendix, where you could move that leg in that position and patient would have a tenderness. The most common used scoring system around the globe is the Alvarado scoring system, which actually is also called as the Mantral score. But because that was a bit complex, I think if you look, it was based on the mnemonic migration. For M, anorexia, nausea, tenderness in the right iliac fossa, rebound tenderness, elevated temperature, leukocytosis, and shift of.
So I think you're muted. If you can just unmute yourself and repeat again. Dr. Parmar.
Hello?
Yeah, if you can please repeat again. You were muted for a few seconds.
So, okay, maybe, I don't know, did we miss after the clinical signs? So as I might, it's the rebound tenderness, rousing sign, psoas sign, and the obturator sign. I don't know whether you heard before, but Alvarado is the oldest scoring system which is used for acute appendicitis. Originally, it was known as the Mantral scoring system, and it was based on the mnemonics migration, anorexia, nausea, tenderness, rebound pain, elevated temperature, leukocytosis, and shift of leukocytosis, and that was the Mentrol, but now popularly known as the Alvarado scoring system. But as I said earlier, appendicitis in my hand is still more of a clinical scenario. Only in young females who would have, say, you are confused with a tubo-ovarian pathology, I would arrange for an ultrasound scan to help. Or if it was an elderly, in case I'm worried about malignancy or something, I would go for CT scan. Otherwise, majority is still clinical diagnosis. Next slide, please. This is the Alvarado scoring system's points. If you can see here, everyone has 1 point, and leukocytosis and right telecosa tenderness has a couple of points. Based on 0 to 10, it is either less likely, equivocal, or probable appendicitis, or highly suspicious of appendicitis. Click next, please. So this is another scoring system known as the ARES scoring system. They have, as you know, besides the Alvarado, they have now, because of the use of CRP, and I think they have added that as well in the scoring system. And the points are 0 to 4 again for low probability, 5 to 8, 9 to 12. And this helps us to predict how likely the patient is suffering for appendicitis. So these are the two scoring system. This is the Anderson scoring system, which is basically a modification of your Alvarado scoring system. Next one, please. Yeah. I think investigations, we all know, once you have the high suspicion, you would do blood test, and you look for leukocytosis and CRP. As I mentioned, for pediatrics or maybe young females, you don't want to start giving them CT scans. And if there is a doubt, you would get an ultrasound scan if that facility is available. CT scan probably in my hand is more in an elderly patient or somebody youngish, but you are suspecting some other pathology. Recently, MRI has now become quite popular in this cohort, mainly for very young kids with some other pathologies. And also, I would say number one would be for pregnancy, when in your first and second trimesters, you are a bit worried about the diagnosis, because as you know, with the different trimesters, your appendix gets moved up and up, and your patient would present even with right upper quadrant pain. So in those scenarios, MRI is more preferable. Just to let you know, again, there is some evidence or some mention in the American Radiological Society that MRIs can affect the hearing or those movements in fetal hearing system. So just to be aware about that. I think talking of management here, treatment, conservative treatment is and was not taken into much consideration before, but since the pandemic, it has become a bit popular again. And I'll show you in the next slide later on where to read for that. Operative, I think it's quite straightforward. For open appendix, you make an incision at the McBurney's point, but I really doubt many people do open appendectomies now. I think majority, I would like to ask later on to the audience here as well, whether majority still do open, or I think everybody has moved to laparoscopic operation only. Again, I won't go more in the technical details of it, because I think people are experienced surgeons here. If there's a nice healthy base, I think a couple of endoloops to the base is fine. The only thing to mention is once in a while, you will come at a scenario where your base is edematous and thick, including a bit of cecum. And in those cases, endo-GI linear stapler, either blue staple height or a green staple height, would be a perfect solution. You don't really even need to oversew it, but after that, if you're worried, you can take few sutures on the staple line as well. And think, obviously, in rare scenarios where you get caught by, say, an indurated cecal base, or if the history was long-term and you were misguided, you do, or if it's a Crohn's or so patient, in those scenarios, you do end up doing a right hemicolectomy, but those are rare scenarios. We should have rather picked it up early rather than having to make that decision during the operation. In case of abscesses, again, sometimes you might not perforated appendix, you might not be able to find the appendix. It might be all gangrenous and eaten up. In those cases, you just need a good washout, leave a drain next to it, and or one drain in the pelvis as well, and leave it, give antibiotics, and you take it from there. I don't need to go into detail about the Ochsner-Sherin regime. I think everybody would have heard of the Ochsner-Sherin regime, which we practice for conservative management when it comes to appendicular abscess or appendicular mass. So mainly, if a patient with a long-term history present with appendicular mass, then that's not the time to go in. You make a marking on the skin, have a good discussion with the patient, and treat with antibiotics. Keep an eye on it. If the patient becomes septic, you might have to then go in. These days with the radiology, in case it then develops into an abscess, you could put a radiological drain and drain that abscess. But again, that would be in patients who would not be fit, or if you're too late in that stage, you could drain that abscess and then give a long course of antibiotic, call the patient in 6 to 8 weeks' time, and then talk about interval appendectomy if needed. Yeah, and again, if this was a scenario in an elderly patient, sometimes you're worried about an underlying cecal cancer. So in those scenarios, what you would do is, once the patient is discharged, maybe at 8 weeks' time, do a colonoscopy to see that there is no underlying cancer. And if that's the case, then you plan for an appendectomy. I think appendix is routine, and we normally don't tend to keep an eye on histology. But if you are worried, if it is looking odd, please look out for tuberculosis or carcinoid or even occasional cancers. If any of this pathology is found on histology, I think then the best is to discuss in your local MDT and then manage accordingly, either by the oncologist or by a specialist team. Thank you. Next slide, please. This is a link for UpToDate, which is where you would find the most. I mentioned about conservative management of appendicitis. So this is where you would find the most up-to-date evidence on management of acute appendicitis in adults. Yes. So if, for people who want to do that, have a look. Just what you need to know is, yes, conservative management is possible. Certain points which need to be highlighted to the patient is, if there is a case of appendicolith within the appendix, which is a trigger, then chances of failure of conservative management are higher. In 25% of the patients, acute appendicitis tend to come back, and it can be more severe with higher complication rate compared to the first episode. So again, that needs to be mentioned to the patient as well. And in 75%, if lucky, nothing needs doing. So that's probably what. And I think, again, for conservative, worth mentioning that at a later stage, if it gets, then the chances of complications are higher compared to if it was done during the first episode. So worth mentioning that to the patients as well. Thank you. Next slide. So next slide, please. That's all about appendicitis. Here, practical points. Coming to hernias, I think we'll focus today only on groins and umbilical hernia, because if you start including incisional hernia, that becomes another topic in itself, with all the abdominal wall reconstructions and component separations and things going on at the moment. So that would be another 40-minute lecture in itself. So we can't cover that in emergency. But I think everybody would have encountered groin or umbilical hernia. Depending on the blood supply, it can either be reducible, irreducible, incarcerated, or strangulated. Strangulated is where you need to start acting immediately, because, as the word suggests, your blood supply to it is compromised, and the whole idea there is that you don't want the bowel to get ischemic and don't want to lose that. So act immediate. Incarcerated, yes, you still have some time, but again, it kind of is a urgent scenario thing. Majority of the cases, when it comes to investigation, there would just be a good history of a patient having a swelling there, and then you find the lump gets irreducible and gets tender. So that's in the majority of scenario you would have. But again, if there is any doubt, and mainly in the elderly, I'm kind of now more inclined to do a CT scan for exactly knowing the pathology and working out what's going on. Again, in the middle of the night, let us say it was 1 o'clock at the night, and in an elderly patient or so, and if you wanted to decide whether there is bowel content within the hernia sac or not, maybe a CT scan would be a good choice of investigation, because then that would help you plan whether you need to do it in the middle of the night or whether you can defer it and do it in the morning in a more controlled way and with people around. Thank you. Next slide. So I think when it comes to emergency inguinal hernias, the standard open approach is still quite popular. I don't think I have seen anyone start doing laparoscopic approach in emergency scenarios for that. So just for people to be aware. For obturator hernias, if that's that's a rare diagnosis, I think it's 1 or 2% chance. In those scenarios, a laparoscopy treatment is a better option, where you either do a tap or a tap repair, depending on your expertise, and you could put an Ultra Pro or a Prolene mesh. Ultra Pro is a mixture of Prolene and Vicryl, or you could put only a non-absorbable mesh, or a combination of non-absorbable and absorbable suture like an Ultra Pro for that. When it comes to femoral hernias, again, depending on your expertise, people still tend to do open. But if your diagnosis was in dilemma, or clinically you couldn't feel a lump and you think it's more of an intra-abdominal component, which is a problem, and there's small bowel, you could do a laparoscopic approach, because that way you can assess the small bowel there as well. Because as we all know, in femoral hernias, chances of strangulation are higher compared to an inguinal hernia. As you see on the right side, I'm sure you guys would have used those. Those are the plugs, which makes quite life easy when it comes to femoral hernia repair. You simply put that plug in the femoral canal, and then you can put few sutures on the psoas and the pectineus and that ligament above, and that would hold it securely. Next slide, please. These are the different types of femoral hernias. We don't need to necessarily, classify into those things, because your management doesn't really change. But just if somebody wants to sound clever, it's good to know this name: the Loger's hernia, Seraphinase, Hazelbeck's hernia based on the triangle we know of, Nereid's hernia. So those are the femoral hernias there. The commonest approach used these days are either the Lothinson's approach, as you can see, that's the high approach, the low incision or the Lockwood approach, or you can use the vertical incision, or what is known as the McCavity's approach. I have realized in my personal experience that when it comes to elderly frail patients where you have a doubt of diagnosis, McCavity's could be easier, because if you need, you can just go through your fascia in, open the sheet, and you could go in the abdominal cavity as well if needed. Thank you. Next slide. So coming to the umbilical hernia, you again, in an emergency scenario, open is a straightforward one, but let us see, if there was a patient with obesity, BMI 50 or so, where you have a small hernia, and in those scenarios, laparoscopy would be a good modality as well. There are different meshes available, and there are different instruments to fix that mesh. So if people have not used this, the standard meshes are fine, but you have some plug systems. So on the top is, I think that's probably a Medtronic one, I'm not sure, but that's a plug system where they're quite easy. So one goes below the fascia, one leaf, and one leaf stays above the fascia, and you can secure it, and it gives a reinforced kind of repair to your umbilical hernia. The right one below, again, is something similar, but the thing in that is the lower one, the blue color one, is a combination of, again, absorbable and non-absorbable material, and it's quite nice and floppy, and would fit in nicely when you want an umbilical hernia repair. And then you put few sutures on the lower mesh and a few on the top bit as well. The two tacking systems are the ProTack and the Secure Strap. The difference between this is ProTack has a titanium pins, which are metallic, obviously, can cause a bit of pain and soreness, whereas the secure strap are PDS material, so they are in long-term absorbable. So that's the advantage of a secure strap or absorbable tags compared to the metallic ones. Next one, or in some scenarios, I've not put the diagram here, but you can even use glue like Liquiband, the N-acylate butyrate glues to secure the mesh, and the evidence is that the pain is less to secure that in the long term compared to when you would have used tacking systems. Next slide, please. These are another few examples of mesh. This is the Peritex mesh. It's a composite mesh. So you have the mesh on the top. Again, pardon me if you have already used it, but people who have not used it. So you have a proline also material on the top, but on the below lower level, on the side facing the small bowel or the peritoneal cavity, you have a collagen film. So that means it prevents your small bowel sticking to the mesh, and therefore theoretically less chance of adhesions and less chance of small bowel sticking there as well into this mesh. On the right are not the previous one still. If you can see, those are the biological meshes. There are different ones called Permacol, Biosyn, and things depending on where and what you want to use in scenarios where there is infection going on and there is strangulated tissue there and you've done resections and all and you're worried that there would be an infection to the mesh. In those scenarios, you can use a biological mesh there. Next one. Next slide. Now we come to the perforation, and we had decided to talk about gastric and duodenal perforation during this talk. So that's what we'll briefly cover here. So again, I think it's good to have a bit of detailed history in these scenarios. What were the aggravating, relieving features and symptoms to differentiate whether this is a gastric or a duodenal perforation. But again, I think these days we have a lower threshold of just doing a CT scan and an X-ray rather than going into much history. But I think it is good to know that before. Always good to have a history of smoking, alcohol, NSAIDs, steroids. Also, people would have had H. pylori infections, because that would help you where the patient already had H. pylori first-line eradication therapy, second-line eradication therapy, or you need to go on to third-line eradication therapy. So it's good to have a bit of that history before going in to do that operation as well. If in the history, it's good to pick up whether there is any associated weight loss or a history of hemoptysis or so, because that will again help you with, suspecting whether this is going to be a cancer or whether let us say a free gas was picked up just on the erect chest X-ray, whether you want to do a CT scan or not, just to see what's going on. So that history helps in the planning. Plus, it also helps in talking about prognosis and future plan with the patient as well preoperatively, and that helps in the consenting process as well to explain the patient about morbidity and mortality with that as well. And with weight loss, you do a bit of nutritional assessment as well. Then comes investigations. I think you do the A, B, C, because these patients can present with sepsis and unwell. If they present early, it's fine, but many a times they present late. So A, B, C is the airway, breathing, circulation. So basics again, but always remember the ABCs before starting doing antibiotics and CT scans and things. I have had few episodes where you would see that patient has had nothing and directly end up having a CT scan. But please do the ABCs before that. Erect chest X-ray, I think, is the kind of standard investigation where we see a gas under diaphragm. Just to remember, though, that in around 5% of patients, sometimes you would not have gas under the diaphragm. So if you have a high index of suspicion in those patients that this is a perforation, go for a CT scan or so. Mainly from my bariatric aspect, if patient had a Roux-en-Y gastric bypass and if there is a perforation from the remnant of the gastric stomach, there would be no free gas necessarily, because the remnant gas would all be absorbed over time. And therefore, if there's a perforation in that gastric or duodenal area, you necessarily will not have free gas, and your CT scan will probably just pick up some free fluid around the gastroduodenal area. So just worth knowing that. In that case, go back and ask a detailed history. Briefly mentioning about sealed perforation, once in a while you will come across patients who the perforation would have healed if it was a tiny pinhole perforation. And in that scenario, if the patient is otherwise well, no peritonitis, no other sign symptoms worrying, you could treatment conservatively with drip and suck, IV antibiotics, a long course of PPI. But in that scenario, probably in 6 to 8 weeks' time, when things have settled, I would arrange an OGD to look at what's going on as well. Next slide, please. This is our standard. So this is when, if you have to do the operation, you can either do laparoscopic approach or an open approach based on the expertise available. I think, having said that, still open is quite popular or commonly used. I would not say popular, but more commonly used. Depending on the time of the day or night as well, probably I think open would be a choice. You don't want to start doing a laparoscopic case if you're not an expert or training someone at 2 o'clock at night if that needs to be done. On the right, you can see the different ways we can close the perforation. It can either just be a primary closure, which I don't think anybody does now. The more popular ones are the C and the D, where you can either do an omental patch repair, which is known as the Colin Jones repair, where you do a primary repair first with the, as you can see, the omentum is between, or you can do a free omental flap, or which was historically actually known as Graham's patch. But these days now, whatever we do with the omentum, we tell Graham's patch for all, but there is actually a difference between Graham patch. There, it was only a free pedicle of omentum used for that. So you could either use a pedicle flap, or you could either use a free flap. I think pedicle flap is more popular and commonly used because your blood supply to the omentum is maintained. Or you could also use, if sometimes if your tissues are cutting through, you can also use it just as a plug. So you could just plug the omentum in the big hole if needed. I think then obviously patient needs a thorough lavage, and you could leave a drain in the subhepatic pouch. Closing the abdomen, there have been different ways. You can either do a mask closer or you can do, the tiny bites, but I think mask closer is still popular and is still proven, I think, with no additional issues or worries about incisional hernias. I think traditionally we can just use skin staples. It's not a problem. If there was a gauze post contamination, if the patient has played and there was a lot of pus and muck and you expect the wound to have an infection, you could do a wet dressing to begin with as well. I did not mention here, but I don't know whether people have heard, there are something known as rectus sheath catheters. So you put them beneath the fascia or the peritoneum, and they are known as pain busters. And you can put that before the closure. So then afterward, that's a good way of pain control as well. Next one, please. Next slide. Yeah. In case where there are large perforations, I think, and if you cannot close them primarily, you can either do a distal gastrectomy. The configurations are either a Billrod 2, which was historically done, which is on the left diagram, but I think safer is now a Roux-en-Y configuration, and which has a better long-term outcomes, less problems with ulcerations and dumping and all issues and cancer risk in the long term as well. There is also something known as a serosal jejunal patch repair. That's the last diagram here. Let us say you're not able to approximate the tissue, the perforation, and you don't have momentum and you're worried. You simply take a patch of jejunum up and you put bites through the jejunum, through the healthy part of the stomach, and use your jejunum as a patch to cover up that perforation. In a rare scenario, if it's a cancer or not operable and you can't do much, you simply leave drains around. You could decompress with either a vent. You could either put a Foley's catheter in the omentum, in the duodenum, and vent it out and simultaneously do a GJ anastomosis and disconnect your stomach through it. This is more of a scenario, rare scenarios, but in cases where cancer inoperable or it's a humongous 4-centimeter ulcer and you're stuck and you can't really do much. In that case, you end up doing it. I think post-op management would be quite variable depending on which part of the world you are, whether you believe in enhanced recovery or not, but they should all go on antibiotics. They should all have H. pylori eradication therapy. You should look out for risk factors, and in the post-op scenario, tell them to avoid those. And as I mentioned, you tend to do a repeat OGD in 6 to 8 weeks time, mainly if you're worried about something like an underlying gastric malignancy or an ulcer, to check what's going on as well. So that's that. Thank you. Next slide. Briefly about gastroduodenal bleeding, which can, I think a lot of countries now have separate gastroenterologists who deal with this, but there are still many countries where this is still dealt by the surgeons as well. So I'll just briefly give you an idea. First is known as a Rockel scoring system, which helps us predict the risk of in-hospital bleeding or mortality. As you know, those are the parameters there. You do the scoring, or any score of 2 or less are considered low risk of developing any adverse outcome. And a patient with pre-endoscopy Rockel score of 0 are considered low risk. So they could probably even just go home and have it on a different day or an expedited way if you are suspecting an upper GI bleed. So that's the Rockel scoring. Next slide, please. And then there is something known as a Glasgow Blanchard scoring system. Here, again, patients with upper GI bleed who have a total score of 0 are considered lower risk. Again, in those scenarios, if things are busy, they can have an early outpatient endoscopy, would be an effective option rather than do it again in an emergency. And this scoring system has shown to anticipate a risk of intervention and death as well. So use this scoring system. Again, it helps in conversation with the patient during the emergency scenario. Next slide, please. If endoscopy fails, so you can either do endoscopy and go there. As you know, now you use multimodal therapy. So you either, historically, they only use adrenaline, but now all the evidence, including the British gastroenterology guidelines and the American SAGES, they all show that a dual therapy is more effective than a single therapy. What that means is you can use, so different ways are either injection, you can have thermal like argon or so, you can have mechanical therapy where you apply clips on your bleeding points, or you can have topical therapy. What it means is you either use snow or like a hemostatic agent on the bleeding point or the ulcer where it is bleeding. A combination of two is a better way and gives better results and less chance of rebleeding compared to only one modality of treatment. Again, depending on your scoring system, as I mentioned, if you can do an endoscopy, if it is in control, if the score is low, you can even try a second go at endoscopy the next time. However, if you fail, then in that scenario, you end up using radiological modality if you have that facility, and that is known as, that is for the gastroduodenal artery embolization as shown in that picture, and that would prevent your bleeding. Next slide, please. Surgical management in those scenarios, again, I rarely see this, to be very honest now. I think I have done probably one in last 3 or 4 years. But remember, when you are called as a surgeon for this, means patient has already failed endoscopic therapy, already not possible with radiological. So they are normally in a bad shape and more unwell, hypotensive. So this kind of becomes real emergency scenarios. Go in quickly, make a cut on the duodenum, transverse cut. Majority of the times there will be blood. Remember, the endoscopists would have tried putting adrenaline there and injection and snow and all topical agents, and you might struggle to even see things. In that scenario, if the patient is unwell, hypotensive, to get control, first stick a finger in on that ulcer and just wait. Put the finger in, get in control, give the anesthetist some time to catch up with the blood loss, blood transfusion, stabilize things, clean up things around you. And once things are a bit more stabilized, at this stage, communication with the anesthetist is the key and the team members is the key. Once that is done, you can put nice control sutures, these sutures look quite nice and good, but in real life, as you would know, it is not as clear as this is. So in that scenario, you end up taking deep suture, but try to take one on the top and one at the bottom, because if you just take one suture on the top, there is still chance of bleeding or retrograde bleeding. So please do that, and close your either your wherever you put the incision in the other, like, so instead of the C and D closure, you have to oppose the A and B to close it. So close it horizontally. Next slide, please. Mallory-Weiss tear, I want to just quickly mention it. It's basically a mucosal tear. There would be a good history of vomiting, retching vigorously, leading to a tear in the upper part of the stomach near the OG junction. In that scenario, make a gastrostomy. Go in, have a look, and you simply need to put a suture on that mucosal tear, and that should do with an absorbable suture, and that should do the trick. You can close the gastrostomy either with a suture, or if you have the luxury of a stapler, you can just fire a stapler on that gastrostomy as well. Next slide, please. One before, please. Yeah. I briefly wanted to talk on consent and the other things to look out before closing my lecture, because, technically, I think we all know what to do and not. Consent is becoming more and more important with medical legal issues. GERFT is UK based, so it's basically approved by the Royal College, the Association of Great Britain and Ireland. It's known as Get It Right First Time. So you could simply go on those websites. They have best practice scenario documentations, what you would do for appendectomies, what you would do for hernias. They also have not only the consent forms, but they also now have documentations, what they expect that if you would do, say, an appendix operation, what steps do they expect in an operative note? They even have that. Similarly for hernias and other operations as well. So if you've not been there, please go on these websites. It's quite good to have consent forms and operation note pro formas or documentation there, and that helps you in the medical legal scenarios. Next slide, please. This is a bit of an example of what it includes. So if you look here, we have modified it into our London regional area. So, in depth about inguinal hernia, say side, whether complicated or not. What is important here is, if you look on the left side, is the conservative management, which needs now, in a part of consent as well, it needs to be discussed and documented, that you even discussed with the patient whether whether there was an option of conservatively managing either a hernia or an appendix or so. So please mention that as well. When it comes to complication, they have nicely mentioned it as expected, uncommon, rare. So that saves you going through the percentage and things as well. And this would be based on a global percentage. So you can either say you are better than them, and that would make your conversation a bit easier there. Next slide, please. Anesthetic points are covered briefly as well. So that saves you. Next slide. I wanted to briefly mention NCPOD. It is a National Confidential Inquiry into Patient Outcomes, and that what it means is that not every operation has to be done, even if it is appendicitis or perforation or incarceration, doesn't need to be done in the middle of the night. There are now guidelines on whether you need to do it immediately, within an hour, within 6 hours, within 12 hours, within 24 hours, and you can see it's color coded, and that helps you communicate with your staff and patient and the rest of the team what the priority of NCPOD is for that individual patient, and you can plan your operation accordingly. And as I say, it helps in medical legal cases as well, as so that you can say that, look, I follow the NCPOD guidelines. Next slide, please. As I mentioned, mainly that these are the 4 parameters it helps in. It helps in the day-to-day communication with the team and patient allotment. It also helps in the patient experience, because then the patient doesn't sit there waiting and wondering what is happening. You can tell him or her that, look, this is where your time frame you are going to have the operation in. Say if you had an appendicitis and a perforation, patient, and you could argue with the patient and explain it appropriately, saying, based on the guidelines, the perforation patient needs to go first for operation rather than appendicitis, even though the appendicitis patient came to the hospital earlier than that. So that would help you in that discussion as well. Again, that helps for the clinical governance and medical legal aspects. And as I mentioned, it helps with the planning. Next slide, please. This is, again, worth looking. National Emergency Laparotomy Audit. There is a risk calculator, and I would strongly advise everyone who does laparotomies, there are inclusion and exclusion criteria to please use. It was originally before known as the P-POSSUM scoring system, but now they have modified it to the NELA, and they have also submitted the most recent report. It tells you whether it predicts basically the morbidity and mortality of the patient, and gives you an idea whether it's lower is less than 5%, and higher is more than 5%. And again, that helps with the consenting and discussion. Next slide, please. These are the parameters which they mentioned there. Like if you're a high risk patient or a high chance of mortality, you would want a consultant surgeon, consultant anesthetist, whether the CT was reported by a consultant, and those parameters are written, and that helps in your compliance as well. So please read up the NELA most recent report as well. Next slide, please. I'm sure everybody is practicing the WHO safety checklist, but if anybody out there is not using it, please use this. It has different stages of safety checklist. It's sign in, time out, and sign out to just check the right patient at the right time is being operated, right things are being done, and that things like allergy, antibiotics, operations, previous operation history are taken into consideration. And for hernia, say a wrong side is not operated on, and those things are looked after. So please use WHO safety checklist, everyone. Next slide. Last but not the least, duty of candor. Again, this is helpful if there was a complication or a problem or something unexpected happened during the operation. It is always worth having that discussion with the patient and family and documenting that in the notes as well. So this communication should be ideal. Thank you. Next slide. So to conclude, I think we briefly touched on histories and clinical examination. It's not just about surgical techniques now. It's all about documentation, how you talk to the patient, how you consent, what is written in the consent, predicting risk score, WHO checklist, and also follow-up planning. So I think besides surgical technique only, there are a lot of factors now to be looked into as well. Thank you. Next slide. Thank you very much. And I'll hand over now to, I think, Dr. Adam Frampton, my colleague from UK, who's going to talk on things. Handing over back to you, Gaurav. Thank you.
Thank you so much, Professor Palmer. It was a very informative lecture. I'm sure it'll help the surgeons in better handling of emergencies in their practice. Now I would like to welcome Professor Adam Frampton. Let me introduce him. Professor Adam Frampton has graduated from the Imperial College of London and University of Kent. He is a consultant general and hepato-pancreato-biliary surgeon at the Royal Surrey NHS Foundation Trust. Dr. Frampton specializes in complex gallstone diseases, liver, pancreatic, and biliary surgeries. Dr. Frampton has a specialist interest in investigating and treating all benign and cancerous disorders of the liver, pancreas, and biliary tract. Professor Frampton is extremely passionate about research and aims to translate new discoveries directly into improved patient care. Dr. Frampton has also won numerous awards for his research, including the Moynihan Prize, the Sir James Fraser Travelling Fellowship, and the Hunterian Professorship from the Royal College of Surgeons of England. Professor Frampton will speak today on the modern management of gallstone disease. I welcome you, sir. You may please start your session.
Thank you for the invitation and for the audience. Hopefully you can see my screen.
Yes, sir, it is visible.
Great. So thank you, everyone, again. I'm going to talk to you about the modern management of gallstone disease. Thank thank you to Chetan for not including gallstones in his emergency general surgery talk. We'll mention some of this later. So here we go. So this is an overview of my talk. We'll look from the beginning, looking at the basic pathophysiology of biliary colic and cholecystitis, diagnosis, prevention, and then surgical treatment of gallstones, moving on to bile duct stones, looking at endoscopic treatment, surgical treatment. And then there's a few cases to discuss along the way, from very simple to slightly more complicated. But this is a broad overview of gallstone disease, applicable for trainees and consultants. So this is a picture of the gallbladder and the biliary tree. As I'm sure you all know, the gallbladder has a fundus, a body, and a neck, which leads up to the cystic duct, entering into the common bile duct. And the liver produces about 1 liter of bile per day, and the gallbladder acts as a small storage tank with only about a 50 ml capacity. And the gallbladder's function is to reabsorb water and to concentrate the bile. And of course, as we know, the bile is important in digestion, especially of fats. So in the gallbladder lumen, during this concentration of bile, you can have precipitation of crystals of mucin gel and of cholesterol. And often this forms into gallbladder stones, cholesterol gallstones. So gallstones are a major public health problem in the UK and around the world. In the UK, it affects about 20% of women and about 15% of men. And gallstones and biliary disease is actually now the commonest cause for acute surgical admission in the UK, and comprises about 30 to 50% of the general surgical emergency take. As I mentioned, about 80% of gallstones are cholesterol, due to excess of cholesterol. And there are many, this is a multifactorial cause, in the fact that it can be a genetic predisposition. So it can run in families. It can be due to gallbladder dysfunction, intestinal factors, and also cholesterol metabolism factors. The other 20% of gallstones are pigment gallstones. These are black in color. This is associated with hemolytic conditions such as sickle cell anemia and hereditary spherocytosis, also cirrhosis. And brown stones are more common in biliary stasis and infection. And again, it's all multifactorial. So gallbladder stones, what are the risk factors? Well, we know that it's more common in females, and this is due to estrogen and progesterone. The estrogen can cause an increased cholesterol in the bile, and the progesterone can cause a biliary stasis. Hence, pregnant women are more likely to have symptoms, and cholestasis of pregnancy predisposes postpartum females to the formation of gallstones and problems. And of course, women with multiple pregnancies are at higher risk. The oral contraceptive and hormone replacement therapy, therefore, is also a risk factor for stone formation. And we all know from medical school the 5 Fs, the fat, female, fair, fertile, and greater than 40-year-old are risk factors for gallstones. There are also other risk factors, such as patients with high fat diets or cholesterol diets, obesity, rapid weight loss after the type of bariatric surgery that Chetan performs. Cholesterol-lowering drugs can change your metabolism, of course, and precipitate out cholesterol. Patients on TPN, patients with Crohn's disease, I've already mentioned alcoholics and cirrhotics. Diabetics are more likely to have gallstones and are also more likely to have complications from gallstones. Hemolytics I've mentioned, and then first-degree relatives, this genetic predisposition. So what are the clinical stages of gallstone disease? Well, the majority of patients, up to 80%, will actually be asymptomatic. And so patients with incidental gallstones do not need laparoscopic cholecystectomy. However, if the gallstone is found to be larger than 3 centimeters, or the gallbladder has a porcelain feature, or the patient has underlying blood disorder such as sickle cell anemia or hereditary spherocytosis, this could be an indication to do a cholecystectomy. Of course, for symptomatic patients with biliary colic, these patients are eligible to have a cholecystectomy. In fact, after one attack, there is about a 30 to 50% risk in the first 12 months of having another attack of pain. And in addition, after having an attack of biliary colic, there's a complication rate of about 1 to 3% per year. And what do I mean by that? Well, complicated gallstones can cause, of course, cholecystitis. They can migrate into the CBD, the common bile duct, causing obstruction, leading to jaundice and cholangitis. And these patients may present with the Charcot's triad, which is fever, jaundice, and right upper quadrant pain. Or in the elderly patient, they may present with confusion and hypotension or shock, in addition to the Charcot's triad, and that's called the Reynolds pentad. Of course, CBD stones causing obstruction of the pancreatic duct or irritating the pancreatic duct on the way through the common bile duct can lead to pancreatitis. And then, of course, recurrent attacks of biliary colic can lead to gallbladder cancer, biliary colic and cholecystitis. So, biliary colic, again, this is very simple, going back to med school, is right upper quadrant pain, radiating to the back and the shoulder. It's never on the left-hand side. It's usually aggravated by food, and that's because the gallbladder responds to cholecystokinin in response to fats and proteins in the stomach, and this leads to contraction of the gallbladder in order to empty its bile contents. But of course, if there is a gallstone impacted at the neck cystic duct junction, then of course the gallbladder is squeezing against an obstruction, and so the patient gets severe pain. It's associated with nausea and vomiting, and actually most patients that vomit then feel an improvement in their pain because, of course, they vomited up their cholecystokinin, and so the response to the gallbladder, the signal to the gallbladder is lost. Usually they have recurrent pain, and they would not normally have any fever, and they should, in theory, have normal white blood cell count and liver function tests. These symptoms usually last for a few hours, and so if pain is going on and is not being relieved with simple analgesia, then they should present themselves to their GP or local hospital, as this could be developing into a cholecystitis. Biliary colic can be prevented in about 30% of patients with an adoption of a low-fat diet, and that's going back to what Chetan said earlier about consent, and the fact that you can possibly treat some patients conservatively rather than surgically, so they should be given that option. Looking at cholecystitis, this cartoon shows the scenario of the small gallbladder stone migrating into the neck or the cystic duct and causing obstruction. And of course, an obstructive system will lead to increased pressure, inflammation, and then bacterial overgrowth from the bacteria contained within the bile. And this leads to focal tenderness or peritoneal tenderness, rebound tenderness, or Murphy's positive sign. And there are two options in this scenario. One, the stone which was causing a blockage unblocks itself, and the cholecystitis could resolve spontaneously or with some antibiotics. But in the second option, if the stone does not unblock itself, then you get increased pressure in the wall of the gallbladder, thickening, edema, and this can lead to ischemia of the gallbladder wall and eventually gangrene and rupture. How do we diagnose gallbladder stones? Well, I've already described to you about the risk factors that you'd be looking for, but of course you have to take an appropriate history, and there's a wide differential diagnosis for acute upper abdominal pain in our patients. Imaging is key. Ultrasound scan will diagnose most gallstones with greater than 95% sensitivity, and MRCP is recommended when ultrasound scan is insufficient or inconclusive. Endoscopic ultrasound scan is very useful for detecting gallstones with a sensitivity of up to 98% in patients with typical pain but normal ultrasound or MRCP. CT is less useful as, of course, most cholesterol gallstones, probably more than 90%, are not radiopaque. So this is a very simple case, 58-year-old, very anxious, presenting with epigastric pain for a year, radiating to the right shoulder, worse at night, not actually associated with fatty food. She's also getting acid reflux and nausea during her severe episodes. She's obese, as most of our patients are nowadays, hypertensive, not on any anti-acid or PPI. She's a non-smoker, non-drinker. And so what would you do? Well, given this is a talk about gallstones, we should probably do an ultrasound scan to look for gallstones. And she is having some reflux symptoms, so she would have an OGD. And she was found to have a small gallstone, actually a couple of gallstones, and maybe some esophagitis and gastritis. So, she was treated with PPI, omeprazole, and then she went on to have an elective cholecystectomy, a very straightforward case. Most patients now ask me in the clinic, can gallstones be prevented? And well, of course, yes, if you adopt a healthy lifestyle, diet, regular physical activity, and maintain an ideal body weight, most diseases that we see can be prevented. And it's the same with gallbladder stones and symptomatic gallstones. But of course, reverting to these factors, to this kind of lifestyle, won't necessarily prevent further attacks. Like I said, about 30% of patients may benefit from some conservative management. But once you've got large gallstones there, ultimately, if they're causing symptoms, you'll need your gallbladder out. That moves on to the concept of medical therapy, because most patients that don't want surgery ask, can they be dissolved? And so you probably all know about ursodeoxycholic acid, which is a secondary bile acid produced by intestinal bacteria. It was discovered in the bear. I don't know how they discovered it, but bear is ursus, so that's where you have the urso of the UDCA name. So this ursodeoxycholic acid can help to reduce intestinal absorption of cholesterol and suppress the synthesis of cholesterol, and therefore the bile has less cholesterol saturation and less precipitation of cholesterol. And so in theory, you can use it to dissolve cholesterol-rich gallstones in sludge. I don't know if Chetan still uses it in bariatric surgery, but they used to use this after bariatrics to prevent cholelithiasis. And it's also used in cholestasis of pregnancy, PSC, and PBC. The problem with ursodeoxycholic acid is that it's not very effective. It takes more than 6 months to work, and it only works in about 2/3 of patients. And there's a high recurrence rate once patients stop using it, with about up to 2/3 having recurrence of gallstones within 5 years. So we've been looking into this with 2 other institutions, Birmingham and Manchester, and doing a study called the UPLIFT study, which is ursodeoxycholic acid to prevent symptomatic cholelithiasis in unfit patients. So this is looking at elderly, frail patients with symptomatic gallstones, whether having them on long-term urso and non-operative management can help them rather than non-operative management alone. And so this will be quite interesting study results once it's finished. So moving on to the surgical treatment of gallstones. Well, as I mentioned a couple of times, cholecystectomy is the preferred option for symptomatic disease. We now perform the majority of these cases minimally invasively, laparoscopically and robotically, rather than open. It's a low-risk surgery, as you know. Most patients can have a day case operation, and the operative time it can range from 30 minutes to 90 minutes, depending on the previous history of the patient, whether they've had severe cholecystitis or just biliary colic. The patients are consented for these things, as you know. The open conversion rate may be about 2%. A retained stone falling into the common bile duct ranges from 0.5 to 2%. Bile leak less than 1%. Bile acid malabsorption, something which we must remember to tell our patients, because actually the incidence is much higher than I ever realized in the literature. It could be up to 10 to 20% of patients having this. And it can last 2 to 4 weeks before the bowel and the liver compensate. But for those patients that have severe symptoms going forward, they may need cholestyramine or cholesavolame for their symptoms. Major bile duct injury is now quoted at 0.4%. But of course, you need to inform your patients that this is an extremely low risk, but has a consequence to their life. The critical view of safety now, I'm sure you all know about this, identifying two structures going into the gallbladder, the cystic artery and the cystic duct, to avoid any injury to the common hepatic and common bile duct, and also the portal venous and hepatic arteries systems. This is some intraoperative photos of the critical view of safety to ensure that you've got a nice posterior window, and you can see two structures clearly going into the gallbladder away from the porta hepatis. We now use indocyanine green dye, which is a fluorescent dye excreted in the biliary system. And if you have a look at this slide from my colleague in Amsterdam, you can now inject this at different timings for different types of liver and biliary surgery. So, for example, we now use between 5 to 10 milligrams of ICG injected at the time of general anesthetic induction to allow it about 30 to 40 minutes, the third row down here, 30 to 40 minutes to get into the biliary tree and be excreted into the bile, and therefore highlight the bile duct and the cystic duct. And so here is an intraoperative photo. You can see the large picture on the right-hand side that perhaps this tubular structure is all filling up with green. But once you've done some dissection, you can clearly see that actually the red line is the common hepatic duct and the black line is the cystic duct. And so perhaps in a more inflamed situation, you may have mistaken the common hepatic duct for the cystic duct and made an injury. So in our experience, ICG can aid safe cholecystectomy and perhaps give the surgeon some more confidence, therefore reducing operating time, bile duct injury, and the conversion to open. What is the indication for surgery for acute cholecystitis? Well, so this, there have been various studies and trials, but this is probably the most famous trial, the ACDC trial from Heidelberg in Germany, which is probably one of the largest HPV centers in the world. And Professor Buchler in 2013 published this in the Annals of Surgery, indicating that acute cholecystitis is common. It's, of course, a great burden to the emergency general surgeon service. And by performing early cholecystectomy on acute cholecystitis in operable patients, they were able to show a reduced length of stay from 10 days down to 5 days, reduced costs and reduced morbidity, because of course these patients don't need to come back for further clinic appointments or imaging, and hopefully reduce their number of future attacks and presentation to the emergency service. And they found that their conversion rate was similar to the non-emergent, to the elective scenario. And so the conclusion was that immediate lap chole should be performed for acute cholecystitis in operable patients. And this was then looked at by the Royal College of Surgeons in England. And in 2016, the college introduced this quality improvement project, which is called Chole Quick, or Cholecystectomy Quality Improvement Collaborative. And this has been taken up by several hospitals in the UK. The goal being that 80% of patients that are eligible and fit to have a laparoscopic cholecystectomy should do so within 8 days of presentation. And so at the Royal Surrey, this is our team that have been leading the Chole Quick initiative. This is the pathway. So, of course, the patient's diagnosed with acute cholecystitis, biliary colic, or gallstone pancreatitis. They have bloods and imaging, usually an ultrasound scan. They're assessed whether they're suitable for an emergency cholecystectomy, and if they're appropriate, they're listed onto the CPOD for surgery within less than 8 days. This is the results from, I think this is from 2020. So you can see the Royal Surrey. We were achieving 83% of our patients with acute biliary disease having a cholecystectomy in less than 8 days. So we were actually the top of the lead table there. This is a second case, a 89-year-old lady with recurrent attacks of gallstone cholecystitis, 4 attacks between May and October 2021. Each episode presented to different consultant surgeons and were treated with antibiotics. She presented to my on-call, so I was dealing with her, and we treated her with antibiotics, but after 4 days, her pain was worsening and her CRP was starting to rise. She was overweight. She had mild dementia, hypertensive, chronic kidney disease stage 3, and she's a care home resident. You can see here from her scan in May 2021 that on the left-hand side, the gallbladder wall was slightly thickened with a little bit of fluid around it, indicating acute cholecystitis. We did an MRCP, which showed that her common bile duct was small and without any intraductal filling defect. In October, the CT scan here indicates that the gallbladder wall is slightly thickened again, and there's a bit more fluid around. And then in November, again, slightly even more thickening of the gallbladder wall and a little bit of fluid, as you can see, going over the right kidney. This is just the axial view. What you can tell here is that the gallbladder wall is thickened, but actually there has been some perforation into the liver parenchyma. So what's the scenario now? What would you do? So the options really were, this is her 5th attack. She could have IV antibiotics for a few more days and then a prolonged course of oral antibiotics. She could have a percutaneous drain of the gallbladder, cholecystostomy and antibiotics. She could have a hot laparoscopic cholecystectomy, or, she was in a pretty bad state. She could actually be palliated given her age and medical history. It's a difficult scenario. So my colleague that looked after her before thought she should be palliated. I thought, well, let's get an anesthetic review and see what they think about putting her under general anesthetic. We had a mini HPV MDT, so discussion with my senior colleagues. And then I met with the son about his mother's options. In the end, I decided to take her for a cholecystectomy. This was horrible. It took a couple of hours. And in fact, I wasn't able to show a critical view of safety. And so settled on a fenestrated, so an open gallbladder, a subtotal cholecystectomy, but leaving the gallbladder open with a surgical drain and an expected bile leak. So this is the fenestrated subtotal cholecystectomy. You can see that the gallbladder, the front of the gallbladder is taken off, the contents of the gallbladder is removed, and we leave this little egg cup, which is called the shield of McElmoyle, which is basically shielding us from endangering the porta hepatis. As I said, there's a predicted bile leak, as you can see here. The drain that I left in was draining at least 200 mils of bile per day, so she had an ERCP, which the little red arrows here in the left picture can show the bile leak coming out of the gallbladder remnant. And so she had a sphincterotomy to relieve pressure in the biliary system. And actually, the bile leak dried up and the drain was removed, and she went back to her care home. She was an inpatient for 12 days, but I think we did a good job with her. What about bile duct stones? So CBD stones or common bile duct stones are actually present in about 15% of patients with gallstones. And they should be looked for if the patient ever has a transient episode of jaundice or dark urine, pale stool, or presents with jaundice and cholangitis or pancreatitis. 90% of CBD stones are symptomatic. An ultrasound scan can show CBD stones, or more commonly, dilated intrahepatic ducts or dilated common bile duct. But it would be better if the patient gives a history as above to do an MRCP, which has a sensitivity of about 93% for a common bile duct stone. And if you have access or there's equivocal findings, you should perform an endoscopic ultrasound, which is even more sensitive and specific. How do we deal with bile duct stones? Well, this is done endoscopically in the majority of cases by ERCP, and the endoscopist can use various methods to treat bile duct stones, including stents, balloon and basket trawling, lithotripsy, laser lithotripsy, and now spyglass for direct visualization and treatment. Here at the Royal Surrey, for very difficult bile duct stones, very large bile duct stones, we have a hybrid treatment of these stones. So whereby, look on the left, a PTC is inserted percutaneously through the liver, through the bile duct into the duodenum in order to allow biliary drainage and allow the patient to get over their cholecystitis, for example, or their jaundice. And then if this bile duct stone cannot be treated either percutaneously or endoscopically, we can now do laser lithotripsy through the PTC. If I start the video, you can see here the bile duct stone being disintegrated and shattered into various pieces. And at that point, the interventional radiologist can actually use a basket or a balloon to then clear the bile duct and ensure that all of the fragments are passed. But there's also obviously the surgical treatment of bile duct stones. This can be laparoscopic or open. The transcystic approach is better for smaller stones and cystic ducts, which are larger than 4 millimeters, basically because the scope that we use to go transcystically is now about 3 millimeters in size. It's useful if the common bile duct is less than 9 millimeters in diameter. It's useful if there is a lateral entrance of the cystic duct. You may think about using this if there is severe or mild inflammation, and if your primary laparoscopic skills for suturing are not so great. Here you can see the choledocoscope being put down the cystic duct in the left, and then once that's done, you can use a basket or a catheter balloon to try and remove the stone or push it down. For choledochotomy, so an incision in the bile duct itself, this is useful for proximal and distal stones. Usually the bile duct would have to be of a substantial caliber, because if you're going to open the bile duct and then suture it closed, you do not want to stricture the bile duct. So it would be better if the bile duct is greater than 9 millimeters in size. Useful for patients with small cystic ducts or strange entry of the cystic duct into the common channel. It's okay for mild inflammation. It's better if better to use a choledochotomy if the cystic duct has a sort of pigtail or spiral shape. Better for large stones and multiple stones. And of course, if you're going to do this laparoscopically, you have to have a good suturing ability. Here you can see the longitudinal cut in the bile duct, and then suture closure. So this third case is a 36-year-old lady presented to A&E during the pandemic. Recurrent right upper quadrant pain, colicky in nature, exacerbated by fatty meals, diagnosed with severe acute cholecystitis. Type 2 diabetic, schizophrenic, and morbidly obese with a BMI of 45. As I said, she had recurrent attacks. On the last attack, which was the most severe, and this was actually at another hospital, a local hospital, she needed a cholecystostomy. She then presented to me in April 2021 with jaundice, pain, and pyrexia, and so underwent an MRCP and an ERCP. Unfortunately, she developed ERCP pancreatitis. So if we look at her imaging, this is her cholangiogram at MRCP. You can see that there is a disconnection between the common hepatic duct and the common bile duct in this picture. At ERCP, she was stented, and here you can see the stent in situ in the common channel. So This is the Maritzi's syndrome. And of course, the Sendai's classification of Maritzi's can be from 1 to 5, whereby the large gallstone in the gallbladder is slowly encroaching on the common channel. So you have grade 1, 2, 3, in her case, a grade 4, where the common channel is completely obliterated. And then, of course, grade 5 Maritzi's would be where a stone actually migrates or fistulates into the duodenum, for example. The treatment for her grade 4 Maritzi syndrome traditionally would be to remove the gallbladder and extrahepatic biliary tree and create a hepatico-jejunostomy Roux-en-Y. So how we managed her with analgesia, low-fat diet, weight loss, rehabilitation, trying to get her diabetes under control, and antibiotics for her cholangitis after her stenting. We then spoke to our local bariatric surgeons, and actually they offered her a gastric sleeve for weight loss in order to then allow us to do safer biliary surgery. But after a mini MDT, we decided to take her to theatre for actually a robot cholecystectomy and CBD clearance. So now that we have the robot here at the Royal Surrey, we can do these more complex biliary cases much more easily than laparoscopically. So in this case, we decided to do it robotically and to amputate her gallbladder at the red mark here, the red line you can see, remove the stone, and then close the defect. This is the robot, the robot we use. This is the XI by Da Vinci, the intuitive Da Vinci robot. If you ever have seen patients having robot cholecystectomy, the ports are in a slightly different place. Usually, instead of the 4 ports, which is standard for laparoscopic cholecystectomy, on the right-hand side, you can see that there's usually an assistant port at the umbilical level, either above or below the umbilicus, and then 4 ports, usually in a straight line, just above the umbilicus. This is her operation. So you can see the robotic hook about to enter the remnant of the gallbladder, what's left of it, as it's contracted over the large stone. Here you can see the chicken egg size stone that has eroded into the bile duct. Here you can see the chicken egg bile duct stone being popped out, and the large defect left in the what was the gallbladder on the side of the bile duct. And then this was suture closed with PDS, as so. You can see the blue lines where the sutures were all taken. And she had a drain. She actually went home the following day, and then about 3 to 4 weeks later, her plastic pigtail biliary stent was removed, and she's done really quite well. The 4th case here is a necrotizing gallstone pancreatitis, a 37-year-old lady, again, recurrent upper abdominal pain exacerbated by fatty meals. She presented with pancreatitis of raised amylase with a CRP of 450 and mild jaundice. Again, she was morbidly obese with a BMI of 40. Here on her imaging, you can see the axial and coronal slices of the CT scan, indicating a lot of peripancreatic edema and pancreatitis with some fluid extending around the left kidney, above the left kidney. Here's another picture showing the evolving changes just in the lesser sac. And you can see in the center of that picture, there looks like a little gallstone as well. And another one in the gallbladder. So she's 37, she's got gallstone pancreatitis. Should we do a hot laparoscopic cholecystectomy, given the fact that we're doing 80% of these hot gallbladders within 8 days in patients that are eligible? We did an MRCP to see what's going on with the bile duct, given the fact that the gallstone probably caused this in the first instance, or definitely caused this in the first instance, to make sure that we don't need to clear the bile duct. But given that she was so unwell, her CRP was so high, she wasn't able to eat and drink, she was in severe pain, we decided that she was not fit for a hot laparoscopic cholecystectomy. And instead, she should have analgesia, antibiotics for her cholangitis, and she actually we had to optimize her nutrition because even though she was obese, she hadn't eaten properly for about 2 weeks. And so we inserted a nasovaginal feeding tube at endoscopy to give her nutrition. In the meantime, whilst this was all going on, she went home and then she represented to her GP with pain and fever. And of course, the pancreatitis and the peripancreatic inflammation had then changed or progressed into this collection in the lesser sac abutting the stomach. And this is, of course, walled off necrosis. And so she was planned for an endoscopic ultrasound, hot axios drainage, to drain all of this pus and fluid. And here you can see the endoscopic ultrasound showing the collection in the lesser sac and the hot axios self-expanding metal stent, the mushroom stent, being inserted into the walled off necrosis through the wall of the stomach, with bits of necrosis being removed by the endoscopist and a large amount of purulent fluid draining into the stomach. And here you can see the little hot axios metal mushroom shaped stent between the stomach wall and the lesser sac collection, wall of necrosis, with another little pigtail, plastic pigtail going through the lumen. So she presented in January 2021, and eventually I managed to do her cholecystectomy in September 2021. And we did this electively as a day case. And actually, her gallbladder, by the time we got to it, was all pretty, the whole region was pretty settled down. And so it was worth waiting. I think it would have been an absolute nightmare to go in any earlier. Also, hot axial stent was removed just prior to her cholecystectomy. Gallstones during pregnancy is another topic of discussion. As I mentioned before, you can get cholestasis of pregnancy, and this can predispose these women to gallstones and sludge. But actually, it's probably only about 5% of pregnant women that develop the sludge and the stones, and only about 1% actually get any symptoms or complications. But we can perform a laparoscopic cholecystectomy in pregnancy if the indication is urgent. Of course, as Chetan mentioned earlier, the second trimester is the safest. Of course, the third trimester, it's not really possible due to the gravid uterus and the risk of premature labor. For bile duct stones in pregnancy, well, you can perform an ERCP and sphincterotomy. The pregnant lady will have to lie on her left-hand side with ERCPs to prevent compression of the great vessels, and it should be done by an experienced endoscopist, and the X-ray time should be minimized. Pregnancy, it should be noted that pregnancy is an independent risk factor for post-ERCP pancreatitis, so these patients have to be consented very carefully. So in conclusion, gallstones are a major major public health problem. Biliary disease represents about 30 to 50% of the acute general surgical take. The definitive treatment of symptomatic gallstones is surgical removal of the gallbladder. As I've mentioned, the ColiQuick pathway, this quality improvement pathway, ensures that 80% of eligible fit patients have a cholecystectomy within 8 days in the UK. And complex biliary cases are best managed with an MDT approach, and ideally, if you're worried, a discussion with a hepatobiliary surgeon. And now new technologies such as robots, lasers, and ICG imaging allows us to treat more complex biliary disease with reduced morbidity and mortality. Thank you very much for your attention, and I'm free to answer any questions, and please email me if you'd like to discuss anything further. Thank you very much.
I would also request you to please fill the feedback form at the end of the masterclass. Please post your questions now. So we have our first question from Dr. Theno from Myanmar. Dr. Thain is asking, is leukocytosis always seen in patients with appendicitis?
Hello. Thank you. Thank you for the question. Well, not necessarily. It would also depend on the presentation, where the patient, if let us say a patient, appendix can be in different positions. So if it is touching your peritoneum, it's a free, your clinical presentation will be even quicker compared to somebody who has a retrocecal appendix. In that scenario, your clinical presentation will be a lot later. So yes, not necessarily, but that is why that scoring system, if you have leukocytosis and depending on how it is, it would expect your score more on your severity, but it's more of a clinical suspicion. I can tell you an example. In my son itself, when he had appendicitis, his white cells were normal.
Yeah, thank you, sir.
I think it would be unlikely to have a normal CRP. Wouldn't you agree, Chetan?
Yeah.
I think CRPs usually raise in appendicitis. I wouldn't take a patient to theatre unless they had a raised CRP, I think.
Yeah. And I think that is where, as Adam mentioned, mainly in those young females where you are suspecting a tubo-ovarian pathology and all those, this is where a white cell and CRP, there would be a 5-day history of right iliac fossa pain and the white cell and CRP are normal, then you are at least more reassured that it is more of a tubo-ovarian problem rather than an appendicitis brewing for 5 days.
Thanks, sir. We have our next question from Dr. Nizila Shakya from Nepal. So is there any protocol for diagnosing asymptomatic gallstone disease?
Well, I mean, if they're asymptomatic, you'd
Yes.
be finding them incidentally, wouldn't you?
She's
If
asking
the patient's asymptomatic and they're having an ultrasound scan, then you'd find incidental gallstones.
So I assume, Adam, it sounds like they're asking whether is there a screening thing for picking up asymptomatic gallstones, but I doubt.
No, there's no screening thing. I don't know what you do for your patients post-bariatric surgery, Chetan. Do they have any ultrasounds to look for gallstones?
No, they do go on a 6-month course of ursodeoxycholic acid because that's the time for the rapid weight loss, but they don't. And only if they're symptomatic, we do ultrasounds and things. I think while she mentioned that question, probably worth mentioning about the gallbladder polyp, Adam, because that's something, if incidental picked up, then that needs screening. So maybe she might be alluding to that, Adam.
Yeah, I mean, there's different disease, but gallbladder polyps that are picked up, if there are now European and global guidelines. Usually, if the polyp is small, less than 6 millimeters, you could reassure the patient. 6 millimeters and above, I would normally keep them on an ultrasound surveillance 6 monthly. If the patient has any other risk factors, such as over the age of 60, any other disease such as primary sclerosing cholangitis or ethnicity change, different ethnicity, not Caucasians, then they may need a cholecystectomy. If they're symptomatic, then you can also offer the patient a cholecystectomy because sometimes ultrasound scans diagnose polyps when actually it's a gallstone.
Right. Thank you, sir. So Dr. Yadnar from Myanmar is asking, in emergency hernia surgery, like strangulated incisional hernia, what type of repair is optimal?
Well, it's a good question, and that is why I did mention that when it comes to incisional hernia, I said it's a different ballgame completely altogether. It's in probably a 40-minute lecture in itself now. In old days, it was a straightforward incisional hernia repair. You just oppose and close, mass repair and close it. But I think now it has, there are a lot of different techniques. You could, again, depending on how bad, whether it's irreducible, whether it is incarcerated or strangulated, that would help you decide what kind of repair you want to do. It could either be a simple repair, straightforward suture repair. I tend to do in those scenarios an interrupted suture rather than a continuous, because then at least even if something breaks, you end up with a smaller incisional hernia. You could then also do a mesh repair and leave drains in. You could even do, depending on how and what time of the day you are operating, you could do simultaneous component separation and mobilize things if needed. And as I said, this is all open. If you end up needing a laparoscopic as well, that's where those Paritex Max, again, that depends on the diameter of your hernia, smaller or larger. You could use a composite mesh there. And in case of strangulated with a lot of infection and pus and mark, you could use a biological mesh, and if the tissues don't oppose to each other, you can even use mesh as a bridging therapy. In rare scenarios where I have done a couple of times, let us say patient comes late with ischemic bowel inside and patient is septic and unwell, you could just do what is known as a damage control operation, resect those small bowel, close it with an Aphthera dressing, let the patient go to ITU intubated, settle, and then come back for a relook and do a more definitive surgery then. So yes, incisional hernia and presentation it's a wide range management depending on where and what and stage you are.
He's updated the question, what would be the preferable kind of mesh, combined or mesh alone?
But that's I was saying, Gaurav, it could depend whether it is a simple irreducible hernia where you're taken to theater or incarcerated, then yes, you could use a standard mesh. Or if you're doing a laparoscopic, then I would use a composite mesh, which I sold. And in case of infection, I would use a biological mesh.
Right. So then the question from Dr. Khin Ong from Myanmar is, are there any particular situations that you think you might need to help of ICG during lap flow?
Well, I mean, at the moment, we tend to use ICG for every single laparoscopic cholecystectomy that we do here at the Royal Surrey. But this is just because we have it available and now we're used to using it. We have the scope, we have the molecule, the drug, or the dye, sorry. So we just use it routinely now. I think it's very helpful. If the patient is particularly obese, you sometimes cannot see the dye through the fat, which is covering the bile duct and the border hepatis. But in the majority of cases, once you start the dissection, I think it's quite useful. But yeah, of course, you have to have the laparoscope and the dye available.
Right. So Dr. Kaw Hetet from Egypt is asking, how do you handle a dislodged stone into CBD during laparoscopic cholecystectomy?
This is, well, it's dependent really on your expertise and I guess the time of day or night that you're doing the cholecystectomy. If you're able to put a choledocoscope down the cystic duct, for example, and to clear the common bile duct, then I would try. If you're not confident to do that, then of course you can ensure that you close the cystic duct effectively. I would prefer Hemolox rather than Liga clips in this scenario, and then the patient can have a ERCP postoperatively. If the filling defect that you see is small, then you could get an MRCP urgently postoperatively in the next sort of week or so to confirm that it's truly a stone, because sometimes when you do an OTC, an on-table cholangiogram, you may mistake an air bubble for a stone. I don't know what you do, Chetan.
It's exactly similar, Adam, the management. I think we are planning to buy a 3mm choledocoscope as well. So for people, you can have a 5mm choledocoscope, and for thinner one, you can even have a 3mm choledocoscope, which is easier for transcystic if needed. But otherwise, as you mentioned, a similar kind of management protocol. But yeah, I would stress, as Adam mentioned, I would stress on using a Hemolock in that scenario. And sometimes if hemolocin not available, you could even use an endoloop. I have used, if your cystic duct is thick and wide, I have also used an endoloop, and use 2 endoloops because you don't want that back pressure to leak from that cystic duct.
Definitely. Yeah. And I think what I was mentioning about the small stone or small filling defect, you don't want to do an ERCP on an air bubble, obviously, but also some small CBD stones may pass by themselves. And so rather to confirm with an MRCP than put the patient through the risk of an ERCP.
Agree. And worth mentioning to all that the UK is doing the largest randomized controlled trial on MRCPs and CBD stones, which is known as the Sunflower study, which United Kingdom is doing, which is planning to recruit more than, I think, 10,000 patients in it. And they're looking at role of MRCP and how, as Adam rightly mentioned, that maybe we are overusing MRCP sometimes. So they expect that, smaller stones probably just pass without needing to do ERCPs, because as you know, ERCP has its own morbidity and can have pancreatitis rate of up to 25% if not in an expert hand.
That's exactly right. I think ERCP pancreatitis, the rate of that is higher than we think. Yeah, you're right. I think probably it could be as high as 25%.
Right. So next question is, elderly frail patient who has a small symptomatic gallstone, how should we manage it? And would you do laparoscopic cholecystectomy?
Sorry, say that again, please.
So elderly frail patients who have a small symptomatic gallstone, how should we manage them? Should we do laparoscopic cholecystectomy?
I think you'd have to assess the patient on a case-by-case basis for this. Going back to what Chetan was talking about, frailty, you'd have to see the degree of their symptoms and how fit they were for general anesthetic, and how, what their quality of life is. I think that it comes down to what Chetan was saying about the frailty scores that we use now. It's the Rockwood score. And if the patient was having severe symptoms, then I would have them assessed by a senior anaesthetist in a high-risk anesthetic clinic, and then put the risks and benefits to the patient and their family before undergoing any surgery.
Right. So what will be the role of prophylactic ERCP and sphincterotomy?
Again, it depends on the scenario. If we're talking about an elderly patient, some patients that present with gallstones and sludge and cholangitis, an ERCP, sphincterotomy and clearance of their bile duct, or just stenting of their bile duct with a plastic pigtail stent, could be the definitive management for that patient, rather than progressing to cholecystectomy if they were elderly and frail and not fit for surgery.
So the next question is, should we be using mesh in patients who need small bowel resection due to gangrenous segment and hernia sac as a result of strangulation in inguinal or femoral hernia?
So again, as we discussed, in those scenarios, say there was strangulation, a lot of infected fluid and things, I tend to just close anatomical repair and not try to use a mesh. Once in a while, though, I should say I have used where you have a humongous big defect and you don't really have that good tissue. In that scenario, I have put a mesh with a couple of drains, and I use negative suction drains in that scenario, and then give antibiotics, send the fluid for culture at that time as well, start on broad spectrum antibiotics and take it from there. But normally the rule of thumb is not use mesh. But, again, it depends in that rare scenario. I have used it twice, I think. Adam, have you used a mesh in such a scenario ever?
It's rare, isn't it? It's rare, but I think
the white defect.
Yeah, I think if I was going to, it'd have to be a biological mesh, which are expensive and sometimes not available in the middle of the night, for example. So it's a bit of a difficult situation. Yeah, I would do the same as you. Try and close the defect anatomically if possible. I guess that brings on to a sort of slightly other question. If you were doing a femoral hernia and you had to do a small bowel resection, would you close the femoral hernia with sutures, or would you still use a plug mesh?
In that scenario,
So it was no contamination, just a small bowel resection of a knuckle with no contamination.
I think I would be happy in that scenario just to try and put sutures on and see. And some scenarios, remember, if you struggle with your groin approach in femoral hernia and you're struggling in the middle of the night, yes, it is safer than to just do a lower midline laparotomy if needed to save life and like a bailout situation rather than struggle in the groin.
Yeah, I was going to actually ask you this. Yeah, I think I've moved away from doing the low approach now. If you have a patient with a femoral hernia that has a CT and there's a knuckle there, a bowel, I tend just to do the high approach now, just because it's so much easier.
I do.
Less stress.
Yes, agree.
Because you can struggle with the defect, a narrow defect in the groin.
Yeah, completely agree.
So Dr. Prakash Chaudhary from Nepal is asking, could you explain the protocol in Mirizi 4 type 4?
The type 4 is the scenario that I showed you. So in this situation, obviously you need to do preoperative imaging, CT and MRI. The patient should have a stent, like a plastic pigtail stent in that case that I showed you, to ensure that they're not cholangitic. And then, once they're safe from that point of view, you can optimize them for surgery, as we did, antibiotics, nutrition, planning. And then if you have a robot available or you have the laparoscopic skills, you could try to amputate the gallbladder and remove the stone and close the defect. Or you could do this at the open approach via a subcostal incision. Or if you weren't confident in that, then you could excise the biliary tree and the gallbladder and do a hepatico-jejunostomy Roux-en-Y. It just depends on your skills and what you have available in your hospital. But basically, you need to optimize the patient and then plan very carefully.
Right. So Dr. Yadnar Levin from Myanmar is asking, in necrotizing pancreatitis case, how long should we put the stent for drainage between the stomach and necrotic cavity?
So that lady had her Hodaxios metal stent. My colleague, Tim Worthington, who does a lot of these, who does all of them actually in our hospital, he would normally leave the Hodaxios for about 6 to 8 weeks and then remove it. And during that period, they may have recurrent washouts of the cavity prior to removal. And then after removal of the metal stent, he may place a plastic pigtail stent between the stomach and the cavity just to maintain some patency and allow further drainage. But in general, he doesn't leave the metal stent there for more than 6 to 8 weeks for a risk of it being embedded in the wall of the stomach or eroding into something else. But the plastic pigtail could stay for longer, maybe 6 months.
So Dr. Binaya from Nepal is asking if you could talk about the management of intraperitoneal bile leaks after T-tube removal, post-CVD exploration, pigtail versus ERCP stenting in such cases.
We haven't actually used a T-tube for a very long time in my hospital. I can't actually remember the last time a T-tube was used. So most bile leaks, presumably you're talking about a side hole in the bile duct or a cystic duct leak, would be managed with a washout. For example, if the patient is unwell, a laparoscopic washout, large drains, so a drain next to the bile duct, and maybe a drain in the right subphrenic space, and then the patient would have an ERCP and a covered metal stent in order to close the defect and ensure biliary drainage. So yeah, I can't really comment on T-tubes because I don't think we've used one for more than 5 to 6 years. Chetan, do you have any experience with T-tubes?
Same, I think, pre-COVID, I don't think I have used anything T-tube after that. I don't remember as well, agree.
Right, sir.
I think now we rather are more used to you doing cholecystostomies rather than T-tube. That's more of a plan, and the juniors are more used to cholecystostomy management rather than that.
Yeah, I think during the pandemic there was an increased use of cholecystostomy. I really don't like them because I think they're quite difficult to manage post-insertion.
I don't like them as well.
Difficult to know what to do next. The patient has a tubogram, they have problems with the tube, or the tube gets dislodged.
Agree.
I think if the patient is high risk, then better to have them assessed by a high risk anesthetic team and discuss surgery with the patient. Or just treat them with antibiotics. Try and avoid a cholecystostomy if you can.
I completely agree.
So Dr. Khin from Myanmar is asking, do you think there's an association between gallstone and gallbladder cancer?
I think large gallstones and recurrent attacks of biliary colic and cholecystitis, there has been shown to be a slight increased risk of gallbladder cancer untreated over the years. It'll be a long period of time.
Right. So Dr. Gobinath from Jaffna, Sri Lanka is asking if you could explain more about retained stone management.
We covered this in the previous question. Depending on the size of the stone, you would, if you've found it at OTC, whether you would do an MRCP post-operatively to confirm that there's a stone there and that it hasn't passed, and then to treat it with ERCP. That would be my preferred method of treatment for those retained stones. When you say retained stone, then that suggests to me you found it post-operatively, so the patients come in actually post-operatively with ongoing symptoms, and then you found it, rather than a stone found at OTC. But the management would be the same. Ideally, you should try and pick this up pre-operatively. We're looking at the liver function tests, and if there's any blip in the liver function test, performing a pre-operative MRCP, I guess.
Right, sir. I would request if there are any more questions you can ask now. I think we're done with the questions.
Excellent.
Right, so we have covered all the sessions, all the questions here, and thank you so much for so informative lectures and taking out time to participate in this masterclass. I think now we can formally conclude the masterclass. I would thank you, the speakers, Sun Pharmaceutical Industries, for making this event happen, and also the delegates for participating in good numbers. I request you all to please download your certificates through the tab provided on your screen. Also, do not forget to give us the feedback. This really helps us improve in bringing you future masterclasses. Thank you so much. Thank you, one and all. Thank you.